Good evening, everyone. My name is Michelle. I'm a product specialist here at Oculus. Welcome to tonight's clinical webcast, Streamlined Dry Eye Protocol for Maximum Efficiency and Dry Eye Treatments. You have a text box where you can enter questions. Feel free to enter your questions at any time, and we will discuss them at the end of tonight's webcast. Our speaker tonight is Dr. John L. Schachet. Dr. Schachet has a private practice in Englewood, Colorado, which was founded in 1973, is president and CEO of Eye Care Consultants, a 5-OD primary eye care practice. Practice specialties include contact lenses, dry eye, allergy, corneal refractive therapy, refractive surgery, and post-cataract management, along with treatment of glaucoma as well as most medical eye conditions. Dr. Schachet has been the chairman of the C-Vision Optometric Conference, a position he has held from 1994 to 2020. In addition, he has served as VSP's board committees from 2010 to 2014. He was also a Vision Source administrator in Colorado from 1992 to 2019, during which time he co-authored the Vision Source Dry Eye Protocol in 2018. He has lectured worldwide, authored numerous articles, former adjunct professor of Southern California College of Optometry, contributing editor to the Review of Optometry and the Optometric Physician, former contributing column writer, Primary Care Optometry News, FDA clinical investigator from many manufacturers from 1974 to present. Welcome, Dr. Schachet.
Thank you, Michelle. Well, if you'll let me take it from here, I appreciate it. Thanks very much for the nice introduction. Welcome, everybody. Tonight, I kind of want to talk about this one subject that to me is one of the things that we do in all of our offices, and that is see dry eye patients, but we don't always treat them the same, and we don't always recognize them when we should. Otherwise, we would not be seeing patients skipping around from doctor to doctor to doctor trying to figure out what's going on with their dry eye. So back when I was in Vision Source, along with Dr. Crystal Breimer from North Carolina, we decided to go ahead and put together a dry eye protocol for Vision Source. When we got through, we realized that this protocol was significantly larger than what most offices would want to do. In other words, it was very time consuming for the doctor, and for the patients, it was a great comprehensive way to look at dry eye, but it's not realistic for everyone. We knew that. So I got to thinking that one of the things that we would do, and I got with my partners in our practice, and we decided that we really needed a more streamlined approach. So I decided to design some of the things that I thought were intricately important in what we did in our dry eye protocol that we wrote, but to create it so that it was more efficient, because when you went through the entire protocol, there were just too many things, and many of them were doubled up. So I'll explain a little bit more of that to you. We have here the normal disclosures that all of us that lecture have to give, so you can see that. I'm not going to go over any of that with you. But I do want to talk about the typical dry eye patient, or a patient that comes in and identifies themselves as having dryness or dry eye symptoms. The first questions that we have to ask as the doctor is, what's the reason for that? Because not every dry eye patient is the same. We've always had aqueous deficient dry eye, and at one time, we thought that all dry eye was aqueous deficient dry eye. I've been involved in dealing with dry eye now for over 30 years. And in that period of time, we've learned a great deal about the whole mechanism of dry eye, and realized that the vast majority, in fact, some 85+% of dry eye is really evaporative dry eye as opposed to aqueous deficient dry eye. And at one point, we thought there was just one kind. As we really dissect it further, we realize that there's a lot of different components to this. And if you take a look at what I have listed here, You know, is there an oil component? Is not enough oil in the tear film? Not enough water in the tear film, which take the two basic types of dry eye into consideration. But then there's allergy issues that come about. And for every area of the country, those allergy issues are going to be at different times of the year, some going to be all year long. Inflammation. You know, we have specific drugs out there that are anti-inflammatories that we use for dry eye, and yet they don't take care of everybody's problems. And so we have to say, okay, if they're anti-inflammatories, do we have inflammation? If there isn't much inflammation, we know those drugs don't work. If there's a lot of inflammation, we know we've got a better chance of having those drugs work. When we look at the lids and we take a look at blepharitis, for example, is there bacteria involved in that? Because that's different than the seborrheic approach to blepharitis. From a lid function standpoint, we need to look at things like lag ophthalmos. You know, what happens when somebody sleeps at night? Is the lid open a little bit? Is that why they're having problems, or are they relatively normal in that respect? We need to know where the lid function is. And then are there systemic contributions? For example, all of the medications that people take, and especially as people age, the medications become more prevalent and at higher dosages than they were when we were all younger. And we see that all the time with our patients. And then from the environmental standpoint, you know, where is it that they spend most of their time? Are they outdoors? Are they indoors? Are they in a somewhat toxic environment? Where are these people most of the time? So all these things are important. But if you think about it and you took each and every one of these categories, you could do 3 or 4 different tests in each of these categories and spend a day with the patient, and you know, to come to the conclusion of what you're going to do about it. But we thought that even though they do exist, we need to kind of break it down. Let's make it a little easier for all of us and come to a diagnostic conclusion earlier and then get things treated right away. So I've got the elements that I created in this dry eye protocol, and this reduced protocol. Dry eye history. You cannot get away from history. History is the single most important thing that you get out of this, whether you take it or whether your tech takes the history and you amplify on it, one way or the other, that's extremely important. We happen to use in our office the speed score, and I got involved with that when we in 2013 when we purchased our LipiFlow that we when it first came out on the market. But prior to that, the dry eye studies that I was involved in with the FDA, we used the OSDI score. And while it's very comprehensive, it sometimes is more difficult for patients to fill it out. And so from that standpoint, I like the speed score. It's quick, and I'll show you what it can do that the OSDI can't. Meibography is an important component of, you know, prior to some, I don't know, 7 or 8, 9 years ago, we didn't use it at all, right? Tear osmolarity. Tear osmolarity is one of the functions of determining if you have inflammation, because they're indirect inflammatory results from osmolarity. Tear meniscus height is one of those tests that you can do that give you tear volume, so that you have some idea what the volume of the tear is. And then non-invasive tear breakup time. Why I like these, we do these 2 tests definitely with the OCULUS 5M along with meibography. You know, OCULUS developed an instrument that really is fantastic for dry eye for several reasons. One is it allows the techs to be able to do the testing rather than for us to have to do every test. And then secondly, because you get a visual result, it's easy in consultation to go through those results with the patients and let them see it, rather than you telling them, okay, well, you broke up at 6 seconds or 5 seconds, you know, by the old stopwatch routine. This is more, it's just more significant this way to the patient. We also do meibomian gland evaluation at some point in the process with a little MGE device that originally was introduced by Tier Science. And then our slit lamp evaluation, which always is important, and we'll still talk about that. And then a lag ophthalmos assessment, which is the final thing we do. And then we can come up with a treatment plan that's necessary from that protocol. So I want to go over a couple of the things in the protocol that you need to look for as we do this. And the first thing that I would say is that at least try to screen every patient every year. And I know that sounds like it's redundant, and it sounds like it isn't anything that's so great that it takes a lot of time to do all that. But the truth is that your patients do vary. And where they may not have had dry eye symptoms one year, a year or two down the road, they may very well have them now, based upon all the things that we've talked about here. You know, you need to find out what works for the flow in your office. But you need to do something. The something is what's critical here to prove your patient doesn't have dry eye. Because, you know, at one time we heard, oh, 20% of the population have dry eye, then we'll say 30%, then it was 40%. And really, it's probably closer to 50% in some way. Does it mean that everybody needs to have full dry eye treatment? No, it doesn't. But, you know, the topical solutions out there, the artificial tear market is a multi-billion-dollar market in this country. There has to be a reason for that. People buy that stuff and use it all the time, and we're not even aware of it. So not to miss opportunities and compromise outcomes, it's probably not a good idea to wait for the patients to complain to you. Screen them and we find out what's going on. Now, Dr. Breimer in her office came up with this little quick test, and I kind of like it here. If you're in a situation where you have a tech that does your history before you see the patient, she or he can ask these few questions. Do you ever feel your eyes? Sounds like a stupid thing to ask people, but people that have a significant amount of dryness are aware of their eyes. Do you have to blink often or more often than you think you should? Do you use artificial tears? Back to that marketplace that we're in right now where tears are being utilized so frequently. And are your eyes often red? And if any of these things, if you get a yes answer and it's just quickly noted on the history, then you can pursue it further when you go into your exam at that point. We do ask our patients to fill out this speed questionnaire. And realistically, if we're seeing a patient on an annual exam, we do ask them to fill this out because it does change. I've been doing it long enough now that I can tell you it changes from one year to the next. What I like about it is that you can get a quantitative score, and then in that little gray box that you see on the upper right-hand corner, you can simply just grade the score. And you have to determine for you what's going to be meaningful. In our office, we say that anything where we're getting double digit or greater, we know we better start paying attention to what the patients are trying to tell us. And so I've taken it even from about a score of 8 or 9, anything higher, it's significant, and we may want to investigate the dry eye situation further by doing a dry eye evaluation. Now you can see the OSDI on the left-hand side. It's just more complicated, and with all of the paperwork that we have to have patients fill out these days, most of it's done on an iPad tablet in the office, but this just is very quick, and we get a good idea of where the patients are. And if I look at the main questions that the speed score is asking, when it says here, there's question number 10, and it talks about, do you have fluctuating vision that improve when you blink? If that one is definitely, frequently or even sometimes, you want to discuss that with the patient because in all likelihood, it's due to dryness factors. So that's one of the things that we look at in the exam before we really get started. We also do just a lower lid meibography on every patient that comes in for the annual exam. And, you know, it can be done. Certainly, we use the OCULUS 5M, but I also have a LipiView in the office that I've had since the day I bought the LipiFlow. You know, LipiScan is their latest in that. And there are a number of companies now that have all come out with meibography units, and I've seen really good ones, some that fit on the slit lamp. They're good units, but as a comprehensive unit, if it's going to get one and one only, I like the 5M, and I realize they are our sponsors here tonight, but there's a reason for that. You've got topography, and you have every conceivable dry eye test you'd like to do on there if you feel like you want to expand on what I'm talking about. Plus, then you have a screen that you can send it to your EHR, and you can show the patient what's going on with what you've got at that point in time. But we do the lower lid, and this is what we get when we do that. And we have this little kind of graphic here that shows what a normal, on the left-hand side, what a normal meibography would look like in an ideal case. And then worst case scenario, as you move to the right, it gets worse, where you've got, you know, glands that are totally obliterated here, and you have glands that are just shortened or you know, that we know are starting to atrophy, but they haven't completely done that. And it's our experience that we can still get a gland that hasn't atrophied to be functional, but once a gland has atrophied, it's gone forever. This is upper lid meibography that is done on the 5M, and you can see even with that, you get different grade levels of what the glands look like. The one in the center is more, in the top center is more like you typically see, where the glands are a little bit more tortuous. You can see a couple of them even twirled in and swirled around. That's pretty normal for an upper lid to see. But by the time you get to the lower images all the way to the right, you see these glands that are truncated or shortening. That's not a normal thing. And usually you'll see greater amounts of change in the lower lid than the upper lid. We do the upper lid when we actually do the evaluation, and I'll explain to you how we do that, but that's what we do. We do the lower lid just on everybody routinely, which again, it combined with a few questions we would ask, like the 4 questions we're talking about, or the speed score, or the patient history, and you take a look at meibography at the same time. Now you know that if there are some changes, maybe we should investigate those changes, and the patients will appreciate it if we can get it done early rather than later. When we start into our evaluation, so let's just refocus for a second, and we'll say we've now done our examination, our initial exam, and that exam or the annual exam for the year. And that we have determined that we need to do an ocular surface evaluation or a dry eye evaluation, and we've kind of called it a modified dry eye eval because essentially that's what it is, because we've incorporated these few types of testing, but not everything that we would have done in a full protocol, but enough to give us the information we need to make a diagnosis. So tear osmolarity is the first thing. That patient comes in, we do this, it's a 2-second test. It gives us an idea of what the value of the tear film is in milliosmoles per liter. So the volume essentially at that point, and what the number is at that point of milliosmoles per liter. We know from studies that have been done that anything around 300 or less is normal for the volume of milliosmoles. However, if you start getting higher, we know that that's when you have some potential inflammation that's taken place as the levels increase. Now here's just a video about the
tears form an important film over the ocular surface. Tear osmolarity is the concentration of solutes in the tear film. Tear osmolarity increases due to a decrease in aqueous production and/or the decrease in lipid production, resulting in increased evaporation. As tears become concentrated or progressively hyperosmolar, damage begins to occur on the ocular surface, including the cornea. Left undiagnosed and untreated, hyperosmolar tears become increasingly toxic to the corneal epithelium, leading to the loss of glycocalyx and microvilli. The glycocalyx has charged ions that grab and hold onto water, and the microvilli help retain the water on the corneal surface. The two work together to ensure the cornea is properly lubricated. The loss of glycocalyx and microvilli results in tear film instability and dry spots on the cornea. Hyperosmolarity also leads to desiccation and desquamation of surface epithelium, loss of goblet cells, as well as inflammation and cell death by apoptosis. As surface cells die off, the underlying immature cells, including nerve fibers, are exposed to toxic hyperosmolar tears, which perpetuates ocular surface damage, thus creating a vicious cycle that continues until hyperosmolarity is identified and managed. The quality of the tear film is essential to light reaching the retina without deviation or reflection, resulting in clear, stable vision. An unstable tear film results in dynamic changes in optical aberrations that deteriorates image quality formed on the retina. This can have a significant impact on a patient's quality of life, in addition to eye strain and discomfort associated with dry eye. As a result, osmolarity is an important biomarker to measure so the ocular surface can be managed accordingly, whether you are preparing the ocular surface for surgery, prescribing glasses or contacts, or managing a dry eye patient. Tear osmolarity, a critical diagnostic in assessing ocular surface health.
So as we see with this, when we talk about the tear film being unstable and vision fluctuating, when you have your patients start to tell you that they're getting fluctuating vision, there's a good possibility that there is a hyperosmolar type situation present for that patient. The next thing we look at, and this is captured on the 5M, this is the tear meniscus height. Now, this is kind of a measure of tear volume. It's not an absolute measure of tear volume, but it gives you a good idea of where to start here. And we like to say that if we get when you measure this, and you actually can do that on the instrument, if you're at about 0.25 millimeters of height or greater, then you're going to have a relatively normal tear film. Until you get to epiphora, obviously, then the tear film height's going to be too great. But when you're down around, 0.1, 0.12, 0.13, that's definitely not enough tear volume to keep this eye happy over a period of time. So that's one of the tests we do, and we show the results to the patient. The next one we do is the NIKBUT, or the non-invasive tear breakup time. Again, done on the 5M. This shows areas that have dried out. So you can see whatever the breakup time average would be. If you, and I look kind of at average breakup time that you'll see. It's a video on the left-hand side, and it shows actually the areas that do break. If you can get to around 15 seconds or so without breaking up, it's still relatively normal, and you don't have any real problems with tear breakup time. But if you get 5 or 6 seconds of breakup time, and that's your average, then this shows up as these marks on the video. The thing about this that makes it rather important, I think, is first of all, it's a visual, shows the patient what really is happening with them. But let's talk about the underlying thing. And that is that if a patient were to blink before you actually have an area that's broken up so that you have a dry spot, you're not going to have a dry spot. So but your average patient blinks, what, every 7 to 9 seconds, somewhere in that ballpark. So if your tear film breakup time is at 14 or 15 seconds, that patient is probably fine. But by the same token, if the breakup time is 2 seconds or 3 seconds, and they don't blink but every 9 seconds, now you've got 6, 7 seconds there where the tear film is and the cornea is unprotected. And so you have a greater chance to have corneal staining and have significant dryness. And that's why this test has significance to us. The other thing that we do is we do a meibomian gland evaluation. And this is the little tool that we use. This tool puts enough pressure on the meibomian gland, and you apply it. Basically, it's enough pressure that you can actually see any type of expression of the gland. What you're looking at are 3 different areas. So if you look at the picture on the right, you'll see that's the temporal side. You're looking at about 5 glands on the lower temporal. If you move to the center, you're going to get another 5 glands. If you move to the nose, toward the nasal area, you're going to get another 5. So you're going to evaluate about 15 glands just as a representative value, even though there may be 25 glands or 30 glands. At that point, you're going to just get a few of them. But if all of those are plugged and you can't get any kind of expression of oil, and not gooey oil, but I mean really smooth oil, these glands are not functioning up to par. So we're looking at a couple of different things. With meibography, we are looking at structure and structure only. With this test, you're looking at function. So if you want to take a look at structure and function, you need to do all of these things to find out what's going on with these glands. In your slit lamp evaluation, you're going to, check the lids for blepharitis, which is another component. If you have lots of discharge from the eyelash lines, you need to know about that. You're going to look for any type of gland plugging, or as we've seen with many patients, lid notching. If you see lid notching, chances are you've got an atrophied gland underneath where that lid notch is. And that's one of the ways it shows up. But by then you may have more than that going across the lid margin. Corneal staining. Corneal staining is obviously important, but what I realized early in the game is when we did every dry eye study that I can remember doing with the FDA, corneal staining was a critical factor in that whole thing. And we realized that not everybody stains with the dry eye situation. So it's important to know the ones that do are more problematic than the ones that don't. If you have a significant amount of debris in the tear film, it's going to affect the osmolarity values. So you need to know about that. It could also be there because of allergy issues. So there are things that you need, when you're looking at it, you need to check it out. And then, of course, ocular redness goes without saying. That's definitely an inflammatory marker, and we need to look at that and grade that for the patient as well. And then finally, one of the things that we look at when we're doing any of the testing for the patient before we start treating is what we call a lag ophthalmos test. And this little test was kind of identified and recommended by Don Korb and Carolyn Blackie. And what you do is you just have the patient lean back in the chair, tell them to close their eyes just like they were going to sleep at night. So don't squeeze closed, but just close the eyes. And then you put the transilluminator on the upper lid and you take a look to see if there's any light that's peeking out from between the upper lid and the lower lid, like you see on the right hand picture down in the lower right hand corner. In the lower left hand corner, there's really no light coming out. But if you have that, you very well need to know one thing from the patient, and that is, how do your eyes feel when you first wake up? Not a question we normally ask people, but again, if you start seeing that, you wonder if there's excessive dryness that's occurring when they sleep at night. So you need to actually find out the answer to all of that. So that's the way to look at these things when we start looking at that. So we'll talk about the treatment. So essentially what's been done so far. We've done the examination as normal. We have determined during the exam that this patient needed to have a dry eye workup of some sort, so a dry eye evaluation. We reschedule the patient to do that. And most of those tests, other than the last few, this slit lamp is not something you're going to have your staff do and determine the dryness aspect. Even the MGE is something you should do, and you may want to do the lag ophthalmos yourself just to see what's going on. But other than that, all of these other tests can be done by your staff. So we bring them back for that visit. We have the staff run them through the battery of tests that we do on the Oculus. At this point, we're not just doing lower meibography, we're doing lower and upper. We're doing the NIKBUT, we're doing the tear meniscus height. We're checking that and putting that into their record. And then, and this is where you deviate based on your practice, and we'll talk about that, but either when the doctor then is going to see the patient, which may be at the same day or maybe even at a third visit, depending on what you want to do, then the last components of this are done, and you discuss it all with the patient. Once you've done all of that, then there's treatment. And depending on what you have, you've got to come up with a treatment plan that makes sense. So let's just assume for a minute that the biggest part of what we have going on is blepharitis, or that blepharitis is a component. You can certainly do what's been done for years, and that is hot compresses and lid scrubs. It works, it's conservative, but it becomes a chronic situation, and the patients have to do it for extended periods of time, or possibly forever, and compliance goes down with all of that. We have in recent years have used the BLEPHX instrument. I'll show you what that is, and that one is one you can do in the office. It cleans the lids quite well. The problem is it doesn't last, so you've got to bring the patients in periodically, especially if there's a severe case of blepharitis. And then the newer treatment today is with new lids, and we'll talk about new lids because it really is a great little device that patients can do at home and manage their eyelid scurf, removal at that point, and do it every day. There are Rx meds, the Restasis and Xiidra that we have used for years, and there are nutritionals that you can use for, using omega-3s, which are a natural anti-inflammatory for inflammation purposes. And then there is manual gland expression. And I must tell you, I'm not a big fan of manual gland expression because I've seen glands really damaged that way. I prefer instrumentation. I like the LipiFlow, which is why I got it. It's a thermal pulsation expression. We were investigators for the iLux unit, and I like it, but it's more, practitioner intensive than the LipiFlow. And then TearCare has a unit out there as well. And then now there's a big talk, if you've seen a lot, on intense pulse light. Luminous has the biggest corner of the market on that, but also I saw that Marco is getting into that game a little bit with a unit called the Equinox, which is a low-level light therapy that they're talking about. This is the BLEPHX unit. It has a little spinner on there that once you get it going, you put a tea tree foam on that little foam pad at the top, and then you use it to clean the lids, and you do it in the office here. Very effective piece of equipment. This is the new lids unit. It looks like an electric toothbrush, basically. The difference is on this one, you can't get it wet, so it's not a toothbrush from that standpoint, but it does have a little brush on the end that oscillates, and it's just a little magnetic brush, and they're disposable, so they're easily replaced. And the patient can do that once or twice a day, and you can see that we've got tea tree foam right next to that. So they put tea tree foam on their lids, and I'll show you how that works right here. this is a demonstration of how you do that. First, it's one eye and then the other eye, and this unit is built in that when you turn it on, the first 10 seconds that you have right now, you're going to just rub it across the lids, as you see right there. Patient does that. And then it will turn off automatically, and then you press the button again, you repeat the process on the other eye. And that is once a day, and then you can just wash that off very easily. From the anti-inflammatory standpoint, in terms of nutritionals, nutraceuticals, there are a lot of different fish oils on the market. Let's face it, they're all over the place. You see them in the big box stores, you see them in the drug stores, you see them in the grocery stores. I happen to like this physician recommended nutraceutical PRN. And there's a reason why I like it. I don't have any interest in this company whatsoever financially, so I have no reason to plug it over anything else. But there are a couple of things about it that I like. Most of the commercial preparations that you see on the market contain some form of alcohol, and that alcohol is ethyl ester alcohol, basically. So it's an ethyl alcohol form. The bioavailability of pure fish oil, actually from the fish, if you could take the fish and just squeeze out all of that oil and use that, that's called the triglyceride form of fish oil, and it's 100%. So it's good bioavailability. When you add alcohol to remove the impurities and the toxins that actually are in the fish, and again, that's what happens in these commercial preparations, the bioavailability goes down, a quarter of what it was. So you got about 73, 75%. What I like about what PRN does is they have a re-esterification process. So once you still get rid of the impurities using an ethyl ester base of getting rid of the impurities and alcohol, but then you do a re-esterification. The bioavailability after that increases to over 100%, and that increases the actual levels of EPA and DHA. I'm sure there are other products that do the same kind of thing. This is one that we use in our office, and that's the reason why we use it. Then we start talking about LipiFlow. So for those that haven't seen it, that's what this is right here. It's a thermal pulsation. The wires actually, that you can see there get plugged into the unit, and that heats the lid to about 108 degrees, so roughly 10 degrees over body temperature. And then those little bladders, those clear bladders, actually compress on the lids at different levels of compression and express the glands once the thermal aspect of this thing heats the glands enough to kind of loosen up the debris, that protein that has coagulated inside the glands. And here you see the tear care unit, and you've got IPL there on the right. Typically with IPL, you can only do the lower quadrant, so the lower lid as opposed to the upper lid. They're really not supposed to be used for that. They're worried about, whether you're going to cause any harm to the patient with doing that. And you have to use some goggles and special preparation and a gel and what have you. We had that in the office initially for a while. The patient response to it wasn't as good as I thought it would be, and yet I still think it has value. Typically, it was used for facial skin issues, but for most part, as long as the patient has rosacea, which is the critical factor in that unit because it's off-label otherwise, then you can actually utilize it as a treatment procedure. Now let's go to the next slide. So the IPL here, again, we said is off-label. It's become rather mainstream these days in meibomian gland disease treatment. The newest iteration of this is what Marco is touting and also what Luminous is. It's called low-level light therapy. And what they talk about there is a two-step approach combined with a regular IPL, which is a thermal treatment, and this one is athermal. So it's a photo activation that actually occurs. It can be used on the upper lid as well as the lower lid. So that's some value. This Equinox instrument that's from Marco, I noticed, has 3 different masks that are used: a red light mask, a yellow light mask, and a blue light mask, depending on what you're trying to do with the skin. So the red light stimulates collagen. Basically, the yellow light works on the lymphatic system, and the blue light is more of a purification on a bacteriostatic basis. Again, there's some marketing involved with all of that as well, but that's part of what this is all about. And but from a study standpoint, the recent studies did show that the scores on OSDI were lower after combined treatment than simply just with IPL. So I think that probably the low-level light therapy is just going to be a standalone type of piece of equipment that's going to be utilized. After we've done our treatment, but we'll talk about LipiFlow for a second. After we've done our treatment, we have our patients use a moisture mask at home. We use this derm mask that you see on the left. It has little beads inside. It has a liner. The patients are asked to moisten the liner, microwave the liner with the mask for 25 to 30 seconds, and then put the liner on the eye and the mask on top. It'll last about 5 minutes and keep heat. We do it once a day. It just tends to keep the glands open. For patients that travel, there are other kinds of masks that you can get, and that's what these other ones are that are represented. We also use Retain. That's one of the drops that I really do like after we've done this treatment. These are single dose containers. We have the patients use them twice a day, once in the morning, once at night. They don't have to use drops the rest of the day. And then we have them continue to do that after the treatment is over. We check the patients again at 2 weeks after we've done it, 6 weeks again in about 3 months. Each time we measure osmolarity, we take a look at several factors involved there, excuse me, just to see how they're doing. And then, of course, the various home treatments for other things, blepharitis as well on the Avenova Claridex side, and then these different tea tree foams that are used for the lids as well. And then when corneal staining becomes a real significant issue and you've got heavy desiccation at that point, then we have to go to an amniotic membrane. And there are several of those on the market. We happen to use Procara. I like the Procara Thin. It's easy to insert. It's easy to remove. You leave it on for about 72 hours. It's not the most comfortable thing in the world, but it really does heal the cornea. And when we're all done with that, we pull it off. We tend to use a bandage lens, and that varies per patient as to how long we're going to use that bandage lens. Some people, we're still using a bandage lens a year later. They come in once a month and we just change it out, or if they're a contact lens wearer, they may change it out themselves once a month, but it keeps the cornea from restaining at any point in time. And then lastly, as we get into this it's the scheduling. So I said there's a couple ways to schedule. One is to do this like in 3 appointments, if that's what you want to do. You can see the patient for your regular comprehensive exam. You then reschedule the patient to do your testing, have the techs do the testing, and reschedule to see you. And then you go through and do a consultation, do your MGE and your slit lamp testing, and also your lag ophthalmos testing. Or what we've gone to more in our office now is reschedule for the ocular surface eval from the comprehensive exam. We do a consultation and treatment on the same day that we reschedule. So we have them in a long slot come in, they see the tech first, the tech goes through their tests, they come see us, we go over those and do our little thing, and then we're ready to treat at that point in time, so we can present the treatment plan to them so the patient knows where to go. And all I would tell you on a situation like this is just do whatever works for your office flow and whatever your particular comfort level. You can't do it all on day number 1. The days are gone where we just simply bring the patient in, do the comprehensive exam, and do everything else that goes along on the same day. It's much like a lot of these complicated contact lens fittings. You don't do them on the same day. And it just works well. Patients are used to that because anytime they go see their physician, they have to do extra tests. It's not done at that point. Most of them are done at a subsequent visit. But test what's necessary to make the diagnosis, and that's about all you need to test. Treat according to what your diagnosis tells you. Do you have an aqueous deficient dry eye? Do you have an evaporative dry eye? Do you have blepharitis that's your primary concern? What is it? Or have you ruled that the dry eyes, everything looks good with that? Maybe you've got allergy issues. You just need to figure out what's going on. Your patients, in the end, will benefit immensely from you going to something like this. And this is really a much more streamlined approach than what you would find in a comprehensive ocular surface eval. It works really, really well. And again, I'm going to put a plug in here. I wasn't asked to do this, but I am going to put a plug in again for the Oculus 5M. Great piece of equipment, from the standpoint, if you need a new topographer, you got it there, but you have all this dry eye capability. It is a fantastic piece of equipment, and the patients love it from a PR standpoint. It's terrific. So anyway, I'm done with the formal presentation on this. You'll see on the screen that I do have my email address, and yes, I'm still using AOL for that, which means I'm just, an old guy, right? But it seems to work well for me, and I didn't feel like changing to something else right now. But feel free to go ahead and email me if you have any questions. If you have questions you want to discuss, Michelle, I'm going to turn it back over to you.
Okay. Thank you, Dr. Schachet, for that great presentation. Just a reminder, on your GoToWebinar screen, there is a text box where you can enter any questions you may have. If you missed part of the webinar, or if there's anything you would like to go back and review, you will receive a link to the recording in the next week. Okay, Dr. Schachet, here is your first question. If you have a new patient, what initial testing do you do kind of as your dry eye screener? But along with that, we also have some questions of, what exams do you do in your screener? But with the Oculus Keratograph 5M, what sort of evaluations do you do in your follow-up and also your full workup as well?
Okay. First of all, in the screening, really very simple. New patient comes in, they fill out all the new patient forms and what they have to do, but at the same time, we give them the speed score, so they fill that out. When our tech takes the patient back to do their screening, they do get a lower lid meibography at that point in time, and they get, the history on all of this. If a patient, when they take a look at the speed score, if the patient has indicated that there's any kind of issue, they're supposed to follow up on that. They don't always, but again, that's where your job comes in. Then when you go into the exam lane, you can start asking questions. That's the initial part of it. It just opens the door at that point for you to take a look at these few things and see if there's anything that, may be a problem. And then you go ahead with just your normal exam. Obviously, when you do your slit lamp, you're going to take a look at the glands, particularly to see if there's any that are plugged. But with the patient, you can go over the meibography. If we do that at the same time, we're going to look at topography. So if the topography was done, we just keep all that in the AHR and we take a look at meibography too. So that's what's done initially. Then we ask the patients, if we see that there's a reason to investigate it further, or the patients really are complaining about it, or they want to pursue this, then we'll go ahead and set them up for the ocular surface eval. And at that point in time, we set a long appointment. We have our techs run the tests that are on the Oculus right away. They take then and they do their tear film osmolarity test. They bring the patient back to the exam, and then from there, we do our few tests that we're going to add on to that, and then do a consultation of the tests that were done, because we can project what's been done on the Oculus. We just send it over to whatever room we're in, and we can go ahead and talk about that and show them what's going on. And then if we decide at that point that part of our treatment, let's say, is going to be a LipiFlow, we'll give the patient an option if they want to reschedule to do that alone. If they're really miserable, like a lot of people are when they come in, they want to get it done that day. And so we allow the time to be able to do that rather than having to split it up into 3. But sometimes it'll be a 3rd visit.
Great, thank you. What diagnostic tests do you rely on to determine success or failure for specific treatment?
Well, I always will repeat, from my standpoint, if we're going to determine that we've got a certain diagnosis from the tests we've done, we probably need to run those same tests after the fact. But I will tell you what we look at just off the cuff. When the patient comes back in, let's take our 2-week visit after a LipiFlow, for example. We see him again at 2, we see him at 6, we see him at 6 weeks, and we see him again at 3 months. We, first of all, get a good history. Asking the patient, have you noticed any difference? Do your eyes actually feel any better than they did before? I'm waiting for that as well. At 2 weeks, I don't expect that. At 2 weeks, what I typically will see is that the patient says, no, I really can't tell a whole lot of what's happened in the last 2 weeks. And I'm okay with that because by 6 weeks, their tune will have changed and they will start to notice a difference. It's just what we see clinically. The other thing that I see is I see an increase in tear osmolarity at 2 weeks. Now, we're not sure why that occurs. But what seems to happen is you get an increase in tear osmolarity, and then by 6 weeks, it's come down to about where it was before you started, and then at 3 months, it's down lower, so that the amount of inflammation tends to peak and then decrease. And I think a lot of it is maybe as we express those glands and we send lots of toxins into the tear film, I think that's what increases the inflammatory factor, and then it comes back down. But I can't prove that. I don't know that that's necessarily the case. We could probably design a study and try to figure it out, but that's just what I'm seeing clinically, and I've seen it that way for quite a few years now. So those are the key elements. Now, if they are not really showing us what we need to know, then we'll go back. We'll do another NIKBUT. We'll do another, tear film analysis to find out the tear meniscus height, that type of thing. We can also, look at the oil film, which we've got a way to do that with the, to look at the actual oil layer in the film. From an interferometry standpoint, and we can do that on the 5M as well. So that just gives you an idea. I mean, we take each case individually, but the most important thing, I want to hear from the patient ultimately that they really are feeling better and that this seems to be working.
Great. We did have someone asking, do you use the lipid layer viewing tool on the K5M? But that seems you did answer that just in your last answer there. It sounds like you do use that lipid layer viewing tool. We had another question, which is, what do you do with the occasional patient who's tried all modes of treatment, IPL, LipiFlow, drops, and doesn't respond? Their eyes are still sore and psychologically they've just given up. What's your approach with those patients if you do see them?
Sure. It depends on whether, I've seen them after somebody else has done all of that stuff or whether I've done it myself, right? So I have 2 different approaches on this thing. I can tell you that the ones where we really have gotten good compliance with what we want them to do, especially post-LipiFlow, those patients, they're so few and far between that we really don't have an issue with that. People really do notice a difference. But if somebody, let's say that they had a LipiFlow done by somebody and they never did any compresses afterward, so no heat, they never did any kind of drops afterward, just, lipid-based drop morning and night, they're not going to get the same effect. They're just not. And the reason is because even in a very short order, those glands will close up again. they'll plug up again. So I think you have to just look at your history and see what it is that the patient has gone through, and then ask all the appropriate questions about what's happened after the fact. Did they change their behavior? In other words, for compliance. And if they didn't, now I'll give you a good example. I have a patient that lives in Vail, Colorado. It's about, for those that don't know, it's about 2 hours away. It's up in the mountains. And she comes in once a year to have a LipiFlow done and repeated. And I said, "Why? First of all, why are you doing it?" She says, "Well, I've got the money. It's not a big deal to me." Okay, that's your business. But why not simply do these things that we talk about? Because we've got patients that have had it done once, but they continue to comply using heat and using drops, and they don't have any problems at all. And she said, I know myself. I don't comply to anything. I'm not interested. And, I'll just pay you. So I'm just coming in once a year. There are people like that.
Great, thank you for that answer. Okay, we have an audience member who is asking, how long is your data gathering process? And I think that's dependent on, if it's a patient initially coming in for a screener versus, a follow-up if you scheduled them to come in for a full dry eye workup. How long do you think that it takes your staff to actually gather, or all that time to gather the data?
Well, it does take a little bit longer, even on the initial day. If they're going to do, although, they're very close when they're working the patient up to the 5M, so that meibography is a pretty easy thing to do. They can it's just a technique. They got to get the technique down. But once they have the technique down, it's quick, right? So that doesn't take a lot more time. It takes a little time for the patient to fill out the speed questionnaire. I granted, no doubt about it. So you might spend, maybe there's 5 minutes involved with that on the front end. Then when you do the evaluation, we book a long slot, which for us would be a 45-minute slot. And what we do is we say, okay, the first part of that slot is going to be used by the tech to gather that information. The last part's going to be gathered by us. And depending upon how cooperative the patient was and what was going on at that point, either if we're going to do treatment, we'll do it on the same day, or we reschedule it yet a third time. Then if we're going to do, let's say, just a LipiFlow treatment on one visit, I mean, that's a short appointment, 15 minutes, not a big deal.
Great, thank you. And what is your marketing and promoting that you do for dry eye to bring in new patients? Or are you pulling mostly from the patients that you already have?
Yeah, I really am. We did a lot of marketing initially, both internal and external. I think the internal marketing was the best. I think that gives you, you already got a captured audience, if you will, the people that are coming to see you that theoretically ought to trust what you have to say. After a while of doing that, you get a reputation anyway for dry eye. And I will tell you, and after 30 years of this, I'm pretty well known in the area that I do. I get involved with a lot of dry eye work. And so I think that's where a lot of the patients come from. They hear about it. I'm not really doing any kind of external marketing on this anymore, but I would tell you that if you're going to get started, I think it makes good sense to do both.
All right. Thank you, Dr. Schachet, for that great presentation and great question and answer session. That's all the time we have for tonight. Thank you for everyone who sent in questions, and thanks everyone for joining us. And thank you again, Dr. Schachet.
You bet, and thank you everyone for attending. I hope that if you've picked up even one pearl or so, it was worth your time and effort. Again, should you have any questions for me specifically, about your practice or what you're doing, please don't hesitate to email me.
Okay. This concludes the presentation on behalf of OCULUS. Good night, everyone.